Thank you for watching the Housing Oregon YouTube channel. Be sure to join our network and get involved in the work that we are doing. If you can, please like and subscribe. It helps us build this channel, which serves as a platform to communicate with our members. This video is part of our 2025 annual conference. We're looking for folks to be on the conference planning committee. Please email info@housingoregon.org.
Today, we're at Health Housing Case Conferencing, Homelessness Care. My name is Ruth Atkins, I use she, her pronouns, and I work for Metro Regional Government, just across the street, Housing Department, and of course we also operate the Convention Center, so welcome in. I used to work in Housing Oregon way back in the day, and I just want to say how thrilling it is to see the growth and flourishing of this event with so many new partners and members, and the gala last year was amazing. So huge shout out to Brian and Christina and the Housing Oregon team. So we're really happy to have you here today. We've got an amazing panel of partners from counties, healthcare, and provider community. And here's what we're going to do today. We'll do a little bit of introductions and level setting about the context for this work, and then really turn it over to the experts doing the work to talk about their role and how kind of the nuts and bolts of this practice, and where we see it headed in this kind of frightening moment that we're all in. And then really open it up. We should have plenty of time for questions and dialogue with you all. So, on to the next slide. These are our panelists today, and we have a last slide. I hope the deck will be shared in one way or another, but we have our contact information on the final deck. Love to continue dialogue and conversation with folks who are interested in this work or doing similar things around the state. I just want to quickly go down the line and have each of the panelists introduce themselves, and then they'll each be speaking in more depth. So we'll just start with Yoni and go on down.
Hey folks, my name is Yoni Khan. I work for Northwest Pilot Project, serving extremely low-income seniors in Oakland.
Hi everyone, I'm Nathan Howard. I coordinate street outreach for Washington County and also facilitate our case conference meeting.
Hi, I'm Chris Pence. I work for Clackamas County, and I help facilitate the Health and Housing Case Conferencing in Clackamas County. I'm stepping in for Aisha. I'm not on there. She was sick today.
Yeah, sorry, I forgot to tee that up. Programming note. Thank you so much, Chris, for stepping in.
Hi everyone, I'm Lauren Kelly. I'm from Sonoma County. I work for Aisha.
I'm Spencer Duran with Health Share of Oregon and project manager for health and housing integration.
Awesome. And I'd like to get a little bit of a sense of who's in the room. So if you could just raise your hand. This applies to you. You may have to raise your hand more than once. But curious, who in the room is an affordable housing developer or provider? Anybody? How about a shelter provider? Awesome. Folks with lived experience here. Awesome. How about other social service, supportive housing service providers? Lots of folks, fantastic. Any healthcare folks in the room? Any healthcare partners? Yeah. Government partners, other than our wonderful partners here. Yay. Some Metro team in the house. Yay. Thank you for being here. Other funders, lenders, any other categories of community partners we missed?
Board member and insurance.
Awesome. Thank you.
Architect.
Yay, architect, thank you. Okay, fantastic. So we're really happy you're here. I'm going to give just a little bit of background around the context for this work, and then we will turn it over to the panel. After I left Housing Oregon, I went to Kaiser Permanente, and this health housing case conferencing sort of grew out of an early pilot in Washington County. Back in 2021, I think, there was a national kind of cohort around how can we innovate around health and housing connections, sponsored by Community Solutions, the Built for Zero folks, and the Institute for Healthcare Improvement. Kaiser Permanente was an early partner along with Providence, and then HealthShare joined somewhere along the way. But now it's just really emerged into this tri-county practice, which is really exciting. So I'm now at Metro and have the honor and privilege of working with the counties and providers and HealthShare on one of 6 regional goals as part of the Supportive Housing Services, or SHS measure, that we were so fortunate in the metro area to have the voters pass in 2020. So as part of that measure, there is Regional Innovation Fund, 5% of the measure for regional collaboration and innovation, and we have a committee called the Tri-County Planning Body, or TCPB. Yoni Khan is an esteemed member of that group. And they set 6 regional goals around how can we work better together as a region. healthcare system alignment is one of those 6 regional goals. Greater alignment and long-term partnerships with healthcare systems that meaningfully benefit people experiencing homelessness and the systems that serve them. So that was kind of our charge. The plan was approved in April, and now we're broadening the table and working in a couple key domains. Emerged early on that this cross-sector case conferencing was a key strategy that we really wanted to support regionally. We know, of course, we've got rising client acuity. I don't need to tell you all that. The workforce is stressed. This is true on all parts of the continuum and in healthcare as well, right? So at its core, this is about how can we create those pathways to be able to have the housing and homeless service providers be able to connect to the care that their clients and participants need, and we're really just shared, and we'll talk more about the details of how this is working. For anyone who's outside the Portland metro area, I just want to note, obviously we're incredibly fortunate and privileged to have this SHS resource. The health housing case conferencing practice, though, we were very lucky that Metro was able to support, some capacity regionally to support this work. But the practice itself is not inherently a inexpensive thing to do. It's more around institutional will, political will, convincing the lawyers that it will be okay, and really, working with the partners on a person-centered, trauma-informed approach. So, and I know we're not the only community doing this. We may hear from some of you aware of others. We know around the country there are other communities doing similar work. So we're hoping it doesn't take several years, right, to replicate this practice, that we can normalize, standardize, and really see this practice spread, because we're seeing really, really exciting early impact. So with that, I want to turn it over first to Spencer Duran from HealthShare of Oregon.
Can you guys hear me? Should I grab the microphone? Can you hear me in the back?
Yeah.
You can? Okay, yeah. So Spencer Duran with HealthShare. So we are, here representing kind of the healthcare side of the housing and health space that cross-sector case conferencing occurs in. And we are part of the SHS strategy to accomplish the goals there as well. And so we try and be the convener of the space, working with our county partners, the homelessness services delivery system, and the coordinating on the healthcare side. So whenever we talk about the cross-sector case conferencing, we're talking about more than just sharing generic resources. We want to actually be able to connect individuals to the services and the supports that are specific to meet their needs. It's not just a generic resource that might be available. It's specifically tailored on the fly in the actual virtual space where all of these professionals are gathering to conduct this problem solving, and then try to coordinate after the fact for follow-ups as well. We can try and make sure that the healthcare side is accountable for the commitments that are made, and that the follow-ups occur between the case conferencing sessions as well. So like Ruth was saying, we're trying to develop a more integrated housing, services, and healthcare system for our Tri-County area. And cross-sector case conferencing is part of that. And one of the things that I've been learning about as kind of watching this all unfold is it's as much about connecting clients or tenants to the resources they need, but it's also a lot about cross-systems learning. So maybe if you have a client who has a similar situation in the future, or that maybe you don't have to come to cross-sector case conferencing, maybe you can take what you learned in a previous session and problem solve or use your contacts to find a solution. Let's go to the next slide and just talk a little bit about CCOs as well, or kind of in general. Cool. I just wanted to throw this on the screen just to show that as a coordinated care organization, there's a CCO that serves your area. So, like what Ruth was saying, this isn't just about, the metro funding, or it's not just about, health share as one CCO. The entity of a CCO exists all over. And so, I think that there's a natural partnership between coordinated care organizations and the housing and services delivery system. So there's 16 CCOs all across Oregon. Again, it's kind of hard to read specifically, but I just wanted to convey that the CCO component is not necessarily, a unique resource that is only available in the Tri-County area. So as a health care organization, what is our motivation? Well, the housing and health delivery systems have not always been consistent and in working in concert to solve joint community challenges. But what we are realizing is that our members are also the people that are participating in homelessness services and are receiving the affordable housing resources that are out there. We have 450,000 members across our Tri-County area, largely low-income individuals. So there's a lot of overlap between who has Oregon Health Plan and who is a resident in shelter or who might be living in a low-income housing development. 8% of our members are driving 40% of the hospital stays. So there's kind of a natural alliance there to try and kind of bend those cost curves and to redirect folks to more appropriate areas of healthcare spending and away from emergency department utilization. And we know that housing stability and affordable housing is a very, very powerful tool to kind of mitigate against those unwanted healthcare costs. So next slide. So what is our role? We just try and be the convener. The folks on this panel are the real experts. We just really try and hold it all together, by providing some of the legal infrastructure between the health plans, the counties, and the medical system itself. We do a lot of, health share is just a data machine. And so there's a lot of data analytics that goes into members who go through cross-sector case conferencing. We can look at their healthcare and housing experiences before cross-sector case conferencing, and then what happened after cross-sector case conferencing as well. And we have a few kind of promising findings from the data that are very early on that we're going to go over here in just a little bit. We also try and support the community of practice, the actual practitioners, so we can take things that we have learned and kind of socialize them up and around the Tri-Counties, so everybody can learn and participate about what's going on in their counties. So there's a lot of information we can find with just a first name, last name, and a date of birth, and we can unlock a lot of healthcare resources to try and find what those individuals already qualify for, but they may not be taking advantage of. Yeah, so what are we really talking about? We're talking about an actual virtual space that brings people together at a set time every 2 weeks, or it could be at the cadence that works best for your community members. But you actually do the real work in those sessions to try and connect the resources in real time. And then the follow-ups are almost as important to make sure that people are communicating between sessions and people are actually getting the resources that they need. I think that really just trying to de-silo. Everyone is really trying to look at ways to streamline service delivery, and I think that cross-sector case conferencing, it can really make that real connection, but it can also really work to de-silo and to have people more knowledgeable about their, their, their peer services. Okay, so the next slide, so we have some early outcomes. We know that individuals who go through cross-sector case conferencing, they use the ER less, and they see their primary care physician more. We're looking at a lot of different kind of domains of trying to understand how people flow through the healthcare system, and these are two of the most significant indicators of someone's healthcare journey. So it's not only effective at getting people resources that will help them, it actually also helps the healthcare system itself by driving people to more appropriate uses of healthcare resources. And I think that might be all for
Awesome. So thanks so much, Spencer. Now I'll turn it over to Nathan from Washington County.
Hi everyone, Nathan Howard again. Washington County, so we started our case conferencing practice about 2.5 years ago as a pilot. There was work, as Ruth mentioned, a year and a half before that. It was kind of a big legal journey to get to where we were able to have this case conferencing space, to have the back and forth data sharing between health and housing. But we got there, and so in March of 2023, we began our conferencing, and that started as a pilot in operated out of our winter shelter at the time when we still had seasonal shelters. And since then, it's become just, it's moved from pilot phase to just a normal part of our business operations that we do at the county. And that's been about 2 years now running, where it's just been a standard resource that we utilize. We meet every other week for 90 minutes. It is open to any provider within our network, so this could be contracted street outreach, shelter, housing liaisons, housing case management. Anybody who identifies somebody with a complex care need can submit them for case conferencing, and provided they meet all the right criteria that we need for discussion, they're then added to the next case conferencing meeting that we have. We have the majority of the CCOs present at that meeting to provide feedback. With the exception of Trillium, we have everybody else there, so we have really good coverage in the care coordination and folks available to specifically discuss what they can see within somebody's medical records. We also have some clinics and hospitals present that are able to kind of see different things and provide different feedback than our insurance plans, so we get really good feedback on what's happening with participants in that space. So it's just become a really great resource that kind of just lives in the center of our case conferencing spaces. We have many other case conferencing meetings that happen at the county. We have a street outreach specific case conferencing. We have a shelter long stayer meeting where it's folks who have been in shelter for a long time and are experiencing some barriers to housing. We also have our coordinated entry meeting, and what all those different meeting spaces, basically our healthcare case conferencing becomes a really great resource for those other spaces. When somebody identifies that they're working with somebody and they're having trouble moving them to the next step in their housing journey, they can, a lot of times what we'll do is refer them over to this case conferencing space to where we can really dig into those health specific issues with the right people in the room to be able to give feedback that they can act on immediately. In terms of success stories, I'll hit on a few. They look really different across the board. I think a lot of what the successes are is really the things that we'll never know is in prevention. When we get somebody into this space, we're hopefully preventing a situation from getting worse. A lot of times what we're seeing is folks are coming into different parts of our system, and really their needs outweigh what our contracted providers are able to do. Shelters aren't prepared to deal with all the different medical things that are happening. Street outreach teams are worried that somebody has these complex medical issues and then are sleeping in a tent at night. Our housing programs have folks who are just kind of barely able to maintain their unit, and this is a resource that we can use to get ahead of that before things get worse, ideally. We have had successes in just finding people. We've had folks who are disconnected from either the housing system or the healthcare side of things, and nobody knows where they are. We can use our shared knowledge of what we can see in terms of ER visits, hospitals, or on the flip side, if they've connected with a housing provider, and help everybody connect with that person so that they don't slip through the cracks. We've also, smaller examples, in one of our recent case conferencing sessions, we had somebody that was going to lose their current insurance coverage and therefore no longer able to go to the clinic that they preferred. It was a culturally specific provider that was going to be very important for that person continuing their care. We were able to identify this in the shared space, and during the course of that meeting, we had somebody in there with the power to just say, let's switch that insurance provider to somebody that will allow continuity of care. So again, prevented something that could have been a big gap in their healthcare. We've had other situations where the outcomes haven't been great, but it's been somebody who was able to pass away gracefully in a care facility with support around them, when otherwise that might have been not the case. So even though the outcome doesn't appear great on paper, it was still that person had care with them in their final moments, which is really, really important. So it's just become a really great resource in our county and our community for just allowing us, a big part of the work that we do is breaking down barriers that prevent people from being successful in shelter, being successful in housing. And this is a great resource of breaking down that healthcare barrier that exists. Without these resources, staff many times, if they're looking for a participant, they have to call every hospital in the community. That's a very regular practice for our street outreach teams. They call every single clinic, hospital to try to find somebody. This eliminates that. Without that, they potentially spend 5-6 hours on a customer care line waiting to get a hold of somebody who can say, here's who they're assigned to for their primary care, other things like that. So this just makes life a lot easier for our providers, and then therefore makes care easier for our participants. I think Spencer hit on too, just the idea that our system is getting more knowledgeable on how to navigate healthcare. For folks who attend regularly, we have some folks in the room. I'll point out Chris in the back with one of our shelter providers who is a very regular at case conferencing. And over time, I've just seen how his team has been able to just run with the knowledge that they have now. And I think just across the board, we have a much better idea of how to navigate a very complicated system in healthcare. And then on the flip side too, I think healthcare is beginning to understand how housing operates more, and it's just a nice step forward in integrating the two systems. And then also, it's just a nice space. This work is hard, and especially when it comes to folks who are really navigating complicated healthcare issues, it just creates a community to where we have mutual understanding. We can kind of commiserate with one another and just share the load, because that type of work is really hard, and it's nice to have this space where we can value each other, acknowledge the hard work that everyone's doing, and also do some tangible steps to change what is happening with our participants.
Awesome, thanks for mentioning that. And I should have said up front too, I mean, you'll hear from, there's a lot of similarities in this practice, but also each county having flexibility to do things a little bit differently depending on their needs and their situation, while we're still sort of in this regional community of practice. So now I'm going to turn it over to not Acacia, but Chris Pence from Clackamas County.
Thanks, Ruth. Would anyone like me to use the microphone? Okay, I'll just try to project. So yeah, I'm Chris Pence. I'm with Clackamas County, and we started our case conferencing in March of last year, 2024. We learned a lot from Washington County. Thank you for your leadership. And we also meet twice per month. We now have all of the health plans, like the Medicaid health plan partners at the case conferencing every session. We have a lot of our county homeless services providers sending referrals to the meeting. We have behavioral health care there, the county behavioral health care team. We have aging and people with disabilities from ODHS there. We have the VA, which was a really hard win recently. We got the VA to start attending. And so there's a lot of people there connecting to a lot of different systems of care, which is important because sometimes people need like 2 or 3 or all of them, right? One difference from Washington County, they use a data sharing agreement, which is great because you can send like bulk data back and forth. We decided to use a release of information, which means each participant has to sign it, but it allows us to add new organizations much easier. We don't have to go through like a lengthy legal process to start getting bulk data back and forth. And so that's allowed us to quickly onboard new like health plans, the VA, the new homeless service providers. But there are cons also. Like we aren't getting that big picture data transfer. So there's some data analysis that we wouldn't be able to do that you probably are able to do. And we recently added in November a human services coordinator to our team. So now there's Acacia and me, the program planner, and the human services coordinator all supporting case conferencing. And he started, Chris Wynn is his name, also Chris. He started facilitating it, but he also follows like some high acuity complex cases, and like we'll check in outside of case conferencing with the case manager, with the health plan, to make sure that the plan of care that was kind of designed in that meeting is actually being followed and that things aren't falling through the cracks. He's also going to be, we're also working on a respite program, a medical respite for people discharging from the hospital who are experiencing homelessness. And we're also starting a pilot to have the hospital, one of the hospitals, Providence in Milwaukee, tell us when they have someone in their ER or admitted to the hospital who is experiencing homelessness, so that we can check if they have some homeless service provider that maybe is trying to find them. Like Nathan mentioned, it's very common that, oh yeah, we know someone who's looking for them. That's great that they showed up at your hospital. We can like connect them. We started with just our shelter providers, but we've expanded quite a bit to people in rapid rehousing programs and permanent supportive housing programs. We've been working on like onboarding new homeless service providers that haven't yet started engaging and sending participants, and trying to make it as easy as possible for them. I wanted to share one patient story. Some of them are very simple, like what's my health plan, or what, how do I find a primary care doctor? But some of them are really complex, and shows the power of having all these people together. So I'll call her Anne, a 66-year-old woman. She came to the Father's Heart Day Shelter in Oregon City. She was living in her car but could no longer get out of her car because her legs were so swollen, because she needed a heart surgery that she didn't know how to get. Before she could safely get the heart surgery, though, she needed dental work done. She was using the emergency department as her primary care. She didn't have like an established primary care doctor. So we worked with the case manager, Lynn Gaffney at the Father's Heart, who was amazing. She deserves so much kudos. To help the client sign up for Medicaid. She had Medicare but didn't have Medicaid. That unlocks a lot more options. And then they were able to get a surgery appointment for her, but it was with Kaiser, and then her health plan wasn't Kaiser, and so we helped the case manager help the client to switch it, right? To switch her health plan so that it was covered. She had the surgery. It was successful. She was then able to move into independent living, and last I heard, she's doing well and is housed and has the support she needs. And so health and housing case conferencing really just like advised and connected, but it takes a lot of work from the case manager, from the housing services provider, who like is meeting regularly with the client. So we're just really giving them the skills and knowledge to better support the client and connecting them with other resources, and then troubleshooting if things don't work. We've served about over 100 people to date, and we're trying to continue to grow, like get more referrals, work with more people. And yeah, just to ditto what the others said about building the skills in our case managers and other people in the community. We've seen more recently a lot of things are being like self-resolved, or not self-resolved. I mean, it's a lot of work from case managers and others connecting the dots, but they don't necessarily need as much support from health and housing case conferencing because they kind of know how to navigate the system on their own, how to help clients get where they need to go. So that's been amazing, that kind of ripple effect out from the work.
Great, thanks so much, Chris. And last but not least, Multnomah County.
Hey there, can you hear my voice? Because I'm pretty low. Great, I'll try to project. So Multnomah County was the last county in the Tri-County area to come to this system, and so because we're rather large, rather complex, and we're a little daunted by trying to figure out how to make this work, we decided to take a slightly different angle on how we were going to do this initially. And what I mean by that is the concern of having too many providers at the table, too many different groups at the table, led us to take a population health angle. So what we ended up doing is we jumped in, focusing on a particular population, which was aging, people who are aging, and who were already in supportive housing services, but were about to lose their supportive housing because their clinical issues or other needs were making it impossible to keep that. So we partnered with Yoni's group here to initially try one provider out and just see how it was going to go. The complexity that we embraced, though, is we brought multiple different sectors to the table at the same time. So we didn't just start with healthcare and our healthcare partners, but we brought in aging and disability, veteran services, long-term services, of course, recognizing that a population like the aging population was likely to need more than just healthcare when they stepped into the room. So we walked in and we did it that way. Since then, we've expanded to actually be open to any homeless provider in the area, but we realized at first we wanted to just try that out. So we've been adding providers both from the healthcare and disability and veteran services at the same time that we've been adding in providers across our continuum. We have a slightly different data system than the other counties do and data sharing situation. We actually have both a data sharing agreement and an ROI, which, just leaving it to us to do overkill. The data sharing agreement allows us to do the bulk analysis that we were talking about, but also potentially find people who may not be identified by their providers, but are maybe slipping through the cracks. So we could say, hey, have you thought about the fact that this person is using a lot of healthcare services, but maybe they're not appearing before you saying they need something. Do you want to reach out? We also use a referral system, which uses the ROI to allow us to be able to get anybody we can into our case conferencing. We also case conference every other week with all those providers at the table. And try not to reiterate what a lot of what's going on here, because that's where we begin to look really similar. Same kind of system of bringing somebody to the table, discussing their greater needs. I also do want to reiterate that I think on top of just the incredible outcomes we've seen for the clients, we've really seen that our counties have learned to work together. What I mean by that is, as mentioned, when we identify a resource, sometimes people are really surprised to find that resource existed. So we have a resource cafe internally that's been created and is beginning to document all of the different resources that we're seeing provided and try to create some sort of handbook internally so that people want to, if people reach out, maybe they might not need case conferencing as we were describing, but maybe they can actually just create a relationship with somebody and find out where they need to go. I know we've also had a lot of inspiring cases here today, so I don't want to jump into that. And many of them were people who came for seemingly one thing and found that long-term services and supports was going to wrap around them to get them to where they needed to go, because while they needed a surgery, they had a variety of behavioral health concerns that were making that surgery really complicated to access. So knowing that you were going to have somebody, in one case we connected people to an ACT team, to a PATH team, to long-term services and supports, and a durable medical equipment all in the same spot, because they needed all of those things to first get their surgery, and before they need to get their surgery to be stabilized to get to their surgery. So it was a long pathway. I also feel like one thing to bring up that's been really cool is we recently experimented with actually having the client in the space while we were case conferencing. In the past, what's happened is a provider will bring the client and they will advocate for them. But one thing we've been trying really hard to center is the person who needs the case conferencing, meaning they bring their needs, what they believe they need, not just a list of health concerns that we've seen them have in the past, and they shared what they wanted. And one person shared, I really want to do this, but I don't feel comfortable with you discussing with me without me being in the room. And so we did a lot of education around how do you talk about healthcare in front of somebody who is not comfortable, hearing themselves discussed, and also how do you talk about healthcare in a room where acronyms are so common, where terminology is so common, and it didn't just help everybody to speak about the situation in a much more trauma-informed way, but we actually found that our providers were really thrilled by this, because a lot of people don't like to say when they don't understand an acronym or they don't understand how to access the system. So having people really carefully walk through, this is what's going on, this is what I mean when I say OHP even, or this is what I mean by CCO, it actually helped everyone have a much more fruitful conversation and consider how do we talk to each other, because I think one of the things this is trying to solve is that we're all very heavily siloed, and beginning to understand each other's systems helps us navigate.
Yeah, fantastic. All right, so Thank you to all the amazing county partners and our health share partner. Now we want to hear from a provider perspective, so we'll turn it over to you, Yoni.
Thank you everyone for having me. So I work at Northwest Pilot Project. For over 55 years we've been serving extremely low income seniors who have fallen into homelessness, and we specialize in kind of moving them off the street and providing them with the full spectrum of wraparound services needed to stabilize them. We do everything from, you know, housing placement, rapid rehousing, to permanent supportive housing, and our decades of experience have just established that we've unlocked something around how to provide these services for some really complex people. We specifically work with older adults who are 55 and over, and a lot of you probably know that that's a population which represents the largest increasing segment of homelessness both locally in Oregon as well as beyond national. And I think the thing to be aware of is, just like someone who's, you know, housed and stable has changes to their body as they're aging, if you're on the street and you've been working your whole life and you fall out of the job market because the construction job you've had is no longer feasible because of arthritis in your back, right? Those are the kinds of situations where people fall through the cracks. And so those are folks who often find themselves in our lobby, who have been on the street for extended periods of time without being connected to resources, and little by little we work with them to come up with a long-term housing plan which incorporates a lot of these pieces. When you come to cross-sector case conferencing in particular, I think it's an important thing to highlight just the level of vulnerability that someone living on the street might have to deal with. You're talking about physical health issues, whether that be diabetes, blood pressure, things that might sound simple and common, but you put a person in an apartment and they have a relapse of their diabetes, that could mean the end of their housing. They go to the hospital for a month. Same with an infection, right? So really, a lot of this is trying to get ahead of catastrophe. I think there's kind of two buckets of accomplishments you can look at with cross-sector case conferencing. A lot has been already addressed, but one bucket is the actual intervention. So we've had a number of complex clients who have come through. One was a person who was dealing with depression from the loss of a sibling who had recently passed away. They were also going blind at the same time, and they kept falling in their apartment. And the third piece was they self-medicated through the development of a gambling problem, right? So you had kind of like this trio, which is somewhat common. I don't want to make it seem like it's everyone in homeless services, but like, what do you do when you have such a complex person? And what we were able to figure out was through cross-sector case conferencing, number one, the Homeless Services Agency, my agency in this case, didn't know that the person had already been assigned a primary care doctor, and within the primary care office already had their own medical case manager. That medical case manager was then able to work with them to set them up with cataract surgery so that the sight issue would be developed, and then simultaneously work on the other issues of mental health and addiction. And so what you saw was essentially a plan where everyone was informed. It's a high resource, it's a high resource endeavor, right? You're bringing people from all parts of the system, essentially to explain how we can navigate things, right? So, but at the same time, this person found stability and was able to be permanently housed because of the nature of this intervention. The other bucket is just information sharing. We might bring someone to cross-sector case conferencing because we do not know what their health plan is. We do not know what their primary care doctor is. And they're having some sort of issue. When you're dealing with seniors, if your dentures don't work, that sometimes means you can't eat food, right? So it's not as simple as like, oh, well, it's just dentures, or just they can't see. It's actually getting in the way of jeopardizing their housing. What that teaches our workforce is, hey, we don't need to be, similar to what someone else said, you don't need to be calling up every single hospital and every single clinic to find your client. It kind of gives us, a good example would be, raise your hand if you've been here to PDX, our airport, our great airport, right? So you go into the parking garage, and every single floor, they say, there's 5 spots available if you turn right, and there's 30 spots available if you turn left. And guess what? If there's no spots, you know not to turn. Well, this is an opportunity to kind of create that signage for our workforce, because if you get into the nitty-gritty of someone who's got a caseload of 25 to 40 people, all of whom have complex medical and social needs, we actually need a directive. We need to know, am I gonna be calling 80 places and end up with nothing? Or can you tell me up front that, I'm sorry, this resource isn't available, or you don't qualify for this resource? We're not here to fight with the system. We're here to just understand, is it worth our while to take a right turn? right? And that in turn has the opportunity to kind of diminish the workforce pressure that are on folks to have high caseloads and work on an ongoing basis. So rising acuity is huge. And I think too, there's a lot to be said around kind of a centralized model versus a decentralized model. I think the one thing to understand about nonprofit models like ourselves, we function and we developed out of unmet need, right? So you have to understand, if we get into a conversation on centralization versus not centralization, ultimately, a lot of the nonprofits that are out there providing these services chose to place themselves in the area that had the toughest things going on, working with the toughest community. And so what you try to strike with something like a mechanism like cross-sector case conferencing is, we understand your expertise as a provider serving older age adults or serving culturally specific communities, not in my agency's case, but others, right? We understand that you bring expertise, and at the same time, here's a mechanism that you can latch onto for that information to better uplift the quality of life for the clients who are coming through your door. And that has been really awesome. Ultimately, what you can say with cross-sector case conferencing is the SHS funding that is used for initiatives like this serve as innovation and incubation. And when everyone's on the same page, that's an opportunity to kind of think through expanding and bringing it further once you understand the impact in the community. So to me, this is a very positive story around kind of flipping the question of silos on its head and saying, how do we actually work together to make sure there's no barriers in order to prevent unnecessary suffering of human beings? We're not dealing with widgets, we're dealing with people, right? And a lot of that is case by case, but the mechanism is there.
Thank you so much, Sonia. We're going to open it up to questions in just a moment, but I did want to kind of touch a little bit on, where do we go from here? This is obviously a very promising, flourishing practice, and we're learning something every day and helping folks every day, but how do we, spread the model and not have it take 4 years to get to that first data sharing agreement? And of course, this is a lovely photo here on this slide, but we're facing, there's a massive storm coming over that mountain, or we're about under it already, right? Destruction of Medicaid, all the housing, all the things. So I guess from my perspective at Metro, since we do have the privilege of being able to sort of convene our partners regionally, this is the time more than ever that we need to work together better to serve our folks as best we can in our own community. But I wonder, before we open up the questions, anyone want to just weigh in? There's sort of the doom and gloom of banding together to survive and weather the storm, but there's also the positive of, given that this is really taking root, where you see this going in the future. Any comments or thoughts about that? Lori?
I think there's a couple things that we call out. One is, how do we systematize things and make things more available so people don't have to case conference as much? What can be done through one connection to one connection? So I know that we're working with Health Share on something they're calling case conferencing office hours, and it's basically really short case conferencing. So what can you do quickly and move people through? And it's in this case being offered to outreach partners who are really just need to know a lot of things very quickly. You can take that away. So I feel like that's one. And the other is the kind of system learning. So when we were talking about, every time we talk about something that somebody in the room didn't know about, how do we catalog that and make that really readily available to everybody, so that it's not taking everybody a year to learn everything. And I think that's one thing we often talk about, which is it takes a really long time to be good at case management, right? Because you need to learn all these resources. It shouldn't take that long. If you can make these things that we're learning available to a broader audience, I think we are able to spread the wealth a lot more, if you know what I mean, to everybody around us, and also begin to discover when you discover you're navigating somebody to a closed door. I think that begs the question, why is that door closed? So hopefully it also begins to really prompt us to bring in partners around the door we most see often needed that is not available to us. Why do so many people want to get to breastfeeding? What does that mean? Why do so many people need this one particular service and they can't? It's somebody particular for what's supposed to be.
Can you speak up a little bit?
Yeah, I apologize. I do have a very low voice. I was basically saying that you discover resource gaps by seeing where people can't navigate to, and that's not a fun process, but I think it's also a really good way to do some policy development while you're also figuring this out.
Other reflections about where this practice is heading in the future?
I I would just add that I think in very difficult times with uncertainty, right, when you look at I don't know, I watch a lot of sports with my kids, so like when you look at a basketball coach on the sideline, and it's the middle of an intense game, they're never like giving this speech of, we need to have the heart of a warrior, blah, blah, blah. They're actually they're drawing up a play and making sure everyone knows their role. That's what happens in the moment, right? And so, in other words, you don't need to focus on this big, overarching, crushing thing that's happening if you can nail down the tactics you're gonna use in order to keep people covered. And so, this is a hub where folks are pulled together to basically say, this person's insurance might be relapsing. And sure, you know, the federal level, there's all these changes, but there's still this tactical pathway to keep someone covered and get them connected to the service, right? So it's kind of almost under the radar, figuring out how to rewire the system to get the best outcome while maintaining your values.
Yeah. Anyone else?
You just said it's a platform to start doing all kinds of other cool partnerships. You know, whenever there was a lot of new COVID windows came out not that long ago, like I think if anybody was involved in the emergency housing voucher program, that was a lot of vouchers that hit the street, and that required a partnership between the COC and the PHA. And so if you didn't have that pre-existing partnership, your ability to deploy the emergency housing voucher program quickly and efficiently, you're at a huge disadvantage. So we don't know what's going to happen in the future, but having these partnerships already established, it might create a platform for who knows what, because we already hang out together, we already know each other. So whatever comes down, we already have our friends together, so we're gonna be able to weather that a lot easier. These MOUs, they can be amended to add stuff. When data starts flowing, from HMIS to healthcare utilization data, who knows what we can do with that. But once those pathways and those platforms are present, we can build all kinds of things. And we might be able to build things that can save money on the housing side with, home or CDBG or whatever starts going down. And then if Medicaid over here starts going down, maybe we can figure out ways to save each other money as resources start disappearing.
Great. So now we'd really like to open up to you all. Any questions you might have? Yeah, go ahead.
I have kind of a twofold question. So, one thing I've noticed working on both sides of housing folks and then helping folks maintain their housing is that there can be a disconnect when on someone's house, right? It's we got that number, somebody's house, and then boom, all of their care team disappears, right? So I'm sort of curious about what your continuity of care, like what that handoff might look like. And also, another thing I've noticed is we're focusing on downstream impacts, right? We're pulling folks out of the river, but we're not stopping them from jumping in the first place. So are there plans in the future to expand to currently housed individuals that may be at risk of losing their housing, but they may not be currently connected with homelessness services?
Thanks. And can everyone hear the questions? I can also come around. We're good? Okay. Anyone want to?
We actually started there.
And Lori, maybe you should use the,
Yeah,
the mic.
because that's a good idea.
Any better? Goodness, okay. Yes, we actually started there because we realized that there were a lot of people that, they're in PSH now, they're fine. That's actually not what's going on. Or they got rapid rehousing and they should have gotten a lot more, and that's what they need. So we started there, and so right now, actually, our panel's open to anybody who's involved in our housing system who needs that kind of support, and with particular focus on the idea that actually, like you said, people are not necessarily stabilized just because they receive the keys, or even necessarily because they have a housing navigation. Like a housing navigator is not a clinical support, and I think we often lean really heavily on people for skills they do not have or need to develop on the fly, and this is a better chance to say, hey, maybe there's somebody who's more clinically trained to do this work or has the resources to do the work.
Back on that a little bit too. So our model follows the participant rather than the provider. So kind of a normal journey for us, we may get somebody that has encountered street outreach. They're living outside. They get case conferenced. For us, it could be a month to 2 months to 3 months. During that time, they maybe got sheltered, so they have a new person representing their case there. That's more the shelter person who's now representing them rather than the street outreach worker. And then what often happens too over time is that person who was in shelter maybe moves into housing, and then we just transfer the representative who would come and speak on their behalf would now be the housing case manager. And we kind of do some active outreach to let that person know, like, you're inheriting this new client, and they're on healthcare case conference. Please show up, because we think this is gonna be a great resource for you to help maintain them. So it's just those like really, really warm handoffs along the way. And that's kind of how we've designed ours, just to be really nimble and who shows up on behalf of that person.
And then on the healthcare side, of course, say you've gotten connected to your primary care doc, that office and the health plan, where all, you know, they know kind of who's working with the individual and have a place to be able to support them and continue to collaborate on their healthcare journey. Thanks. Other questions in the back?
So this sounds really positive and beautiful, and I'd love to learn more and see about bringing it to my community. And I have some questions around it, right? Like, as a shelter provider, what we see is taxis, medical transport dropping people off in our parking lot, no phone call. They exceed our level of care, they may be trespassed, all these different things. And so they exceed the level of care to shelter, but then trying to access medical care or senior disability services, maybe they qualify for some of those things, but you can't get a care person to come into shelter. The question is, how does this group engage, like, hospital, senior disability services to get those services, or is that maybe kind of two separate needs? What does that look like?
Thanks. Want to take that one?
I can say a little bit. I think that, look, there's a lot more problems than there are resources, right? And I think that we're just in an environment now where it's apparent to everyone, if you don't pivot and take one step together at a time, then more and more people are gonna be left behind, and more institutions are gonna be left behind. And so, we don't always have the ability to tackle the most difficult things all at once, but what we do have the ability to do is to shepherd a limited amount of resources and say, we're gonna use this to stand up partnerships. And as those partnerships start to demonstrate outcomes, we can think about expanding into other areas. But really the beauty of this is, you know, I've been in the metro area doing social services work for over 10 years. And the beauty of this is, we actually have a functioning group of systems and providers, and often clients, who have the ability to communicate and articulate their needs, and then get a sense of the direction you need to go with. And I think that that learning can be applied in many different beneficial ways. What county do you work in?
Lynn, Benton, and Lincoln.
Yeah, I used to be a legal aid in Lynn, Benton. Yeah, I know, I love that. It's
Yeah.
great area. And, you know, we also have the benefit of local SHS, Supportive Housing Services tax money in the metro, which, you know, is different from other areas. But I will say that I think everyone here is open to learning and tackling things in an iterative way.
Yeah, I would add that sometimes, I'm not sure if this is the case in your community, but sometimes like the hospital team that is discharging them isn't talking to the health plan team that's trying to support them. So if you are able to help that person access, like, I think someone mentioned it, like a care coordination case manager, health plans can like assign someone to follow a client's health plan and support them and make sure that they're getting those connections. That team might be able to better support them than the hospital is trying to just discharge them and then like focus on whoever comes in. So sometimes it's like, yeah, finding the right people that have the ability and goal to support the person longer term rather than just like short term.
I'll add too, I mean, another pillar of this regional work that we're focusing on with the county partners, HealthShare and the others, is that hospital discharge piece. And so interconnected but a slightly different conversation, because it does bring in the hospital partners in a different way. And so it's exactly the type of challenge that you were identifying, and knowing that both systems are under incredible stress. Again, like, can we set up a coordination system so that we can work together better and try to get folks with advance notice to the right level of care and have better collaboration. Even if we aren't always gonna have the resources for folks, at least we have that line of communication. So it's a work in progress, but we'd love to connect and learn more.
Yeah, Ruth is really good at that. If nothing else, a convener, like has the hospitals or health plans literally toured your shelter, you know, Do they know what it means to put someone in a taxi and say, it's not out of sight, out of mind all of a sudden, these are real workers that work a front desk, that are trying to deal with this. I think, some of the, these just, literal cross-sector learning can just also mean, have they physically been there? Have you invited them to tour the space, to show them what it means whenever someone comes to our front door? That educational piece might go a long way, for who knows what in the future.
Well, and you're kind, but like I worked within Kaiser Permanente and we were really on the outpatient side, leaning in on the case conferencing. Even as Kaiser Permanente employees, figuring out how to like get an inroad with the hospital teams was challenging, not because they're all awesome people, but the complexity is just mind-boggling. I thought question here?
Yeah, I'm still trying to figure out how to say this succinctly. I'm wondering, for those of us who are outside of the metro region, was the answer SHS funding that got these to work? Otherwise, who was the entity that did the initial impetus in convening? I guess I'm coming from a county where the county is not involved in shelter and housing or HMIS, and our CCO doesn't do in-person member support and navigation. So I'm just trying to envision for how do we translate, which are the entities locally that would be having a role in this?
Yeah, I mean, the SHS funding absolutely has been a huge help, and we were able to support, positions in HealthShare to be able to help with the coordination. So definitely don't want to sugarcoat how the challenge when you don't have that kind of resource. But it does seem like through the CCF structure, and that's something we're hoping that, we can maybe branch out to in the future, is like, whether it's through, I'm a little scared of OHA, I'll just say. But, statewide, there's opportunity with the other CCOs to be able to, and learn, there's similar practices happening, which we haven't had an opportunity to learn about. But it feels like there should be a way to do this by, again, like just the political will of, yes, we want to be able to serve our shared clients and patients better, reducing healthcare costs and better outcomes, right? Yeah. I don't know if Spencer, you want to add anything?
There's nothing unique about, HealthShare is really cool, and I like working here and all that, but Oregon Health Plan is Oregon Health Plan. There's only like slight differences between what each flavor of Oregon Health Plan is offered by each CCO and by each provider in everyone's communities. So I would think, okay, who's my local CCO? And what is care coordination? So care coordination might be one of the magic words to start unlocking, bringing the CCO to the table. I think that all of these counties are the continuum of care. So that's a challenge you just surfaced, right? So you've got a lot of missing puzzle pieces, but I think that going through the CCO, through the care coordination track, might be one way to start on your kind of journey.
Yeah, and I put up here, this is our contact information. Really happy to connect with folks. We're deep in this work, but we also want to, again, not have to take many years to try to replicate it in other communities. Other comments, questions, curiosities?
Can I ask a really quick one?
Yeah.
Yes, no. What role, if any, do virtual referral platforms like Unitas or Connect Oregon have in this model?
Want to speak to that?
Yeah, we use Unitas to get referrals from housing providers because then we can take case notes, like we can note their Medicaid ID, their insurance information, health risks, who their plan is, in that platform, which is HIPAA compliant, whereas we could not put that information pretty much anywhere else. Our HMIS system is not HIPAA compliant. That said, it can be a barrier because for organizations not already in Unitas, it is a process. Your whole organization has to join, which can take weeks or for some months. So we also sometimes have to work around it, but that's very useful for us to, as free to most organizations in Oregon, HIPAA compliant platform.
Is Unitas still just shelter-based? Like people, it's still serve people just in shelter?
No. You can put anyone's client information in there as long as they agree to it. That the client has to agree to have their information put in Unitas, either verbal or written consent, but it can be anyone.
And I'd say it's pretty much an open question, again, as we're working on, we have each county's, of course, their autonomy, and is there a regional piece that's been on the table, a question mark, or other tools to be able to streamline referrals and that kind of two-way coordination. Any of the other counties want to talk about?
We
their
don't
platforms?
use Unitas or any of the other social care platforms. Our request system is pretty simple. It's a smart sheet that everyone within our system has access to for adding, and then the rest of the work happens through just kind of filtering through HMIS.
We do something between, we have a referral form that's actually on our website, so anybody can go in there and fill it out. It's like a smart sheet on the back, exactly. But in the world of sharing information across platforms, we actually have a bridge site with HealthShare where we're able to all put our information in. Providers get access to it, so you can share that information in a safe space. So not Unitas, but just a couple cobbled together, I want to say, spaces.
Yeah, and of course, always the challenge, you don't want to ask folks to learn and take on a whole new system to be able to get the benefit. So, work in progress.
So you're not using it to refer out to housing providers? That's what we've been asked and how we're kind of, we can't. Okay.
Yeah, and it's finding, I mean, it feels like you've got a slightly different combination of the housing and homeless side as well as the healthcare side in each county. So it's really been fascinating to kind of see the different approaches and kind of expanding to different populations and different partners, but really becoming embedded in each county.
Just to add on to that, we don't receive referrals in for our case conferencing from healthcare. It's all housing driven.
Yeah.
So our housing folks are the ones that are identifying. We wanted to keep the kind of the power with the housing side of things rather than being a healthcare driven initiative.
And you know, back to that 2+ years it took to get the initial pilot off the ground, that was sort of the secret sauce because we kept going around and around like, is it healthcare referring out? Who is it? And that's where you get stuck, right? Because there can be this reality or perception that it's about healthcare jumping the queue to get their patients direct, and does not work. So when we finally landed on was, oh, this needs to be all about healthcare coming to a homeless response space, bringing their help, their resources to really help the homeless service and housing providers. And that, I mean, it still took a while with lawyers to get to yes, but that was really the key, and that continues to be. And you know, ultimately maybe there'll be some bi-directional pieces, but we really needed to start there and build that trust and build that muscle of working together. And so, yeah, that was really the key to getting it off the ground.
I will just add to that the output of that, because yes, referral starting origins are tricky and sensitive, but when we've been doing this long enough, there starts to be a sense of the folks who are coming to case conferencing are shared clients. They bounce back and forth from shelter to the ED to inpatient psych to sometimes correctional, right? And ultimately, there starts to be a sense of you can't define the person by the door they walk through. You can look at their health history, the costs, social and economic, that are generated from that, right? And ultimately, the folks that are being served here, there's just a recognition they can end up in either silo, and that's a cultural change.
And we are doing more analysis of the data. One of the things is looking at it with a racial equity lens, like who is getting served by this, who is not getting served, what adjustments do we need to make to our practice to make sure. I mean, obviously there's all sorts of issues around stigma within the healthcare system, the way folks have been treated historically, systemic racism in all our systems. So that's again part of the learning and the analysis. Like Spencer said, it's really promising early indications that this is really hitting the mark, and we have lots more to do as we continue to iterate and learn together. So, any last questions before I know we're standing between you and lunch? We really appreciate your time today. Thank you to this amazing panel. And thanks for all you do.
Yes, absolutely.